All right, welcome everybody. It is July 25th. This is the Florida EMS webinar. We have myself, we have Tanner Smeda, we have Dr. Paul Pepe, and every week we bring you the best and the brightest from around the country with respect to EMS literature. And this week is no different. Today we have a very hot topic. That's why we see a lot of great names on this call today from all across the country. And today we're talking about traumatic out-of-hospital circulatory arrest. And we have the lead author, Dr. Amelia Breyre, who hails from, she worked at Yale, but now she's at San Francisco General, and she is the San Francisco County, the LEMSA, which is the medical director for the entire county. Very big job. She's got a lot on her plate, and she's writing papers, which in this particular case is a joint position statement. So this is something that should change your practice. It probably should change your protocols. It's a hot topic. It hasn't been modified, I believe, this paper since 2013. So this is a pretty big update here. It's been a dozen years. So her co-author, Charlie Ingram, who is now an associate medical director here in South Florida, is also the FAU EMS Fellowship Director. And to his left, I see Dr. Bengio, one of our first fellows. Welcome. And so, Amelia, without any further ado, if you want to make any further introductions, share your screen and take it away. Thanks for joining us.
No, thank you for the introduction. And let me go ahead and start at the beginning. So yeah, and I do want to definitely kind of shout out to Dr. Ingram here, who is very much part of this process and will help answer some questions at the end if any come up. So the topic of this is a position statement that is a joint position statement between NAEMSP, ACS-COT, so the American College of Surgeons, and ACEP. So kind of the three big groups getting together and decided, based kind of on this paper, endorsed it. So it's pre-hospital trauma compendium, so part of a kind of an ongoing series. And the topic here is pre-hospital management of adults with traumatic out-of-hospital circulatory arrest, which TOHCA is the acronym we're using. So I think we can kind of universally agree that traumatic out-of-hospital circulatory arrest has a poor prognosis. It's really, depending on the region and the population studied, traumatic out-of-hospital cardiac arrest has a survival rate of about 1% to 6%. In contrast, out-of-hospital cardiac arrest of a medical etiology, survival rate 8 to 11%. So really, in general, we all know historically, a lot more poor of an outcome. So kind of starting about where we've been, where the position statements have what they've recommended in the past and kind of trajectory of what we've done here and what's changed. So the first guidelines were created in 2003. They were titled the Guidelines for Withholding or Termination of Resuscitation in Pre-Hospital Traumatic Cardiopulmonary Arrest. And this was really, there was a little bit of a literature review, but this was mostly consensus-based at the time. And basically, there was a distinction that was made between penetrating trauma and blunt trauma was kind of one of the big features. So if someone was apneic and pulseless, then resuscitation should be withheld. If they had penetrating trauma and papillary reflexes, spontaneous movement, or organized ECG activity. And then similarly, if a blunt trauma, if there was no organized ECG activity, that wasn't really kind of defined, those were indications for either withholding or terminating resuscitation. And then there was also this 15-minute kind of rule that came up. Either if there was 15 minutes of resuscitation attempts or a 15-minute transport time, that was kind of a guideline for which you could either withhold or terminate resuscitation. And there was an asterisk there for either drowning, lightning, hypothermia, kind of those being extenuating circumstances where this necessarily wouldn't apply. So that was almost 20 years ago. And then moving on to kind of 2012, there was kind of an update to this. Dr. Millen and his group decided to split this paper into two different position statements, one on withholding resuscitation, and then the other one is really is focused on termination. So there was a structured literature review that was done as part of this. I do want to kind of point out, though, that in 2011, there was the position statement about lights and sirens that was kind of made, and then also one about termination of resuscitation for non-traumatic cardiopulmonary arrest. So that was kind of the setting in which this all occurred. What informed this position statement was a structured literature review. It wasn't a little bit clear exactly what that entailed. The article defined all articles deemed to be relevant were reviewed, but didn't really kind of define what that meant. And we'll talk a little bit about the process that we used and the methodology. So the bottom line, though, is that there weren't really any major revisions to the withholding position statement. The evolution of the science resulted in really, not major changes. So the blunt trauma, still, if there was without organized ECG activity, you could withhold resuscitation. Penetrating trauma, if they had no other signs of life, which was a little bit unclear what exactly that meant, or at least I've always found that unclear. And then basically ECG activity and a papillary response was still kind of mentioned as criteria for withholding resuscitation. So kind of moving on to the other half of the termination of resuscitation for traumatic cardiopulmonary arrest. Basically, it really emphasizing that resuscitative effort should not prolong scene time. And really, it removed that 15-minute time recommendation was kind of a big difference that was noted in this paper in particular. So what did we do? So these are actually, taking a little bit more of a systematic approach. How has the literature evolved over the past 10, 12 years? What we did was looking at specifically what new literature can we use to inform a new position statement or updated guidelines. So this was the methodology we used. The search terms, basically looking at all things that meant EMS, all things that meant trauma, all things that meant cardiac arrest, circulatory arrest. And then that resulted in about almost a little over 1,100 articles. And then this was the systematic kind of structured search that we used. So based on that PubMed search, we screened the records and found there were about 423 that were sought for retrieval. And then from there were a total of 194 studies that were included in these guidelines. So what we did exclude if it was not pre-hospital based. So if the study was only focused on the ED and there was no mention of pre-hospital, that was excluded. If it wasn't related to traumatic arrest, sometimes some of these papers were actually medical arrest papers. Sometimes it was mixed, in which case it was included, but if it was only medical, it was excluded. If it was only pediatric patients, that's a separate position statement, more coming. And then case reports were excluded, case series were included. If it was an editorial or opinion piece, and then articles with only extenuating circumstances. If it's just about avalanches or just about drownings or just about hangings or just about electrocutions, those were excluded. And then in terms of how this evidence was processed, really there was kind of an inclusion of certain interventions based on the frequency that they were encountered on the scientific evidence. So really it was a review of expert kind of as a group, kind of including the surgeons and the emergency medicine physicians, really what we should prioritize in terms of interventions. And the data, and really wanted to emphasize more recent data. There was also some snowballing of search and bibliographies. So if there were certain things that were kind of came up, we would look into the references and added that to our literature. So that was kind of included in that 194. So what's changed? This is the kind of that's the process that we use to kind of inform this, and really. This is kind of the big summary is that at least in the data, in the information, there's just a lot more international trauma data. a lot more kind of being published. And that means that there's actually a lot more blunt trauma that's kind of informing this rather than penetrating, especially when you look internationally, given kind of changes in gun accessibility and gun laws, blunt trauma tends to be a lot more predominant. And then looking at this literature too, there's a lot of like EMS clinician variability in terms of scope of practice. And it is just very heterogeneous. So a lot of the larger studies happen to be from Europe and East Asia, where they have these kind of large integrated registries, in Australia, and the scope of practice is different, the population is different. So taking that caveat and trying to translate this to these are intended to be really American guidelines for our system, which is also unto itself pretty heterogeneous. So the second big thing that I think maybe Dr. Pepe would appreciate too, is that the understanding of traumatic out-of-hospital circulatory arrest is really, it's a blood deficiency. And that's what underlines the collapse. So with that understanding, it may be a different approach needs to be emphasized. So using kind of all that, this is the algorithm that we kind of created that to provide a way of digesting all of these guidelines. So it starts with an assessment of the patient and history and exam. So if there's evidence of traumatic etiology for the circulatory arrest, proceed using this guideline. If not, there's a whole different algorithm for this. That is ACLS. That's your epinephrine, that's your chest compression, so does not apply. Next, are any of the following true? Are the injuries incompatible with life? Decapitation, hemicorpectomy, probably not. Is there evidence of prolonged cardiac arrest? Is there decomposition? And then does the patient have a DNR? If any of those are true, do not initiate resuscitation. If none of those are true, keep going down the algorithm. So if you're going to initiate and continue resuscitation, prioritize life-saving interventions, kind of this idea of an LSI, if clinically indicated. And what that really means is 1, hemorrhage control, 2, airway management, and then 3, potentially thoracostomy. So talking a little bit more about what that kind of all means, hemorrhage control, tourniquet, especially if it's kind of in the extremities, applying direct pressure. Basically, hemorrhage control can maybe make a pulse that was not necessarily palpable, give it a chance, and then maybe you can feel a pulse. So giving hemorrhage control a shot. That's the first line. And then airway management. It needs to be basically a readjustment of the airway. If it's thought to be contributory to the reason for arrest, then intervene. If it needs kind of either a BVM or an advanced airway or even kind of a surgical airway, an attempt at that might be reasonable as part of the resuscitation. And then thoracostomy. If there's any suspicion for thoraco-abdominal trauma, consider doing a needle decompression. That doesn't mean that a bilateral needle decompression is indicated all the time empirically. However, if you have even kind of the lowest of suspicion, it's very reasonable to dart them. So that being the recommendation there. And then this is where it gets a little bit, that the 15 minutes that we kind of kept on talking about, would transport improve this patient's chances of survival? That depends. That depends on your system. It depends on your trauma surgeons and kind of what they want to intervene upon or not. And this is kind of really where you collaborate with your regional trauma system and kind of assess what survivability looks like for you. So if not, discontinue resuscitation attempts. And then if so, transport to the closest trauma center. This is kind of what this algorithm looks like, all put together. And I do just want to kind of highlight a couple of papers that I just thought were interesting and kind of very, very informative. Some for historical reasons, some just because of their conclusions. But this one from 1993 was based in data from Sacramento. But you'll often see in a lot of protocols that if the heart rate is less than 40, the wide complex PEA, that's oftentimes criteria to discontinue resuscitation or terminate resuscitation. And I just always wondered where that was from. And it's actually this paper where any patient with a heart rate less than 40 ultimately died within 2 days. So just a historical interest. There was this big meta-analysis that was done, including 37,000 traumatic arrest patients. And that was from 2020. And basically that conclusion of that paper was that the mechanism of injury was not as important of a prognostic factor in survival. So that's really kind of why this paper in part informed why we didn't make that distinction between blunt versus penetrating trauma in the same way that historically that's been done. The next paper that was really kind of pivotal in a lot of these decision-making was in 2021, a meta-analysis that looked at almost 7,000 patients and epinephrine. And basically the conclusion of this study found that epinephrine administration was not associated with pre-hospital ROSC or short-term survival. So you'll notice that epinephrine is not on this algorithm. And then lastly, the European Resuscitation Council in 2021, this is a verbatim quote. It says, "Don't pump an empty heart." There's not a lot of kind of evidence in the literature about this, but it does kind of follow, our understanding of if it is a blood deficiency, if it's a circulatory arrest, chest compressions necessarily aren't going to help the underlying problem. So the European Resuscitation Council, recommended not doing chest compressions, and this is not necessarily prioritizing it, especially if it's not thought to be a medical arrest. So certain areas, though, I want to acknowledge that there is some information out there. There's some literature, but definitely a lot more is needed. One of which being POCUS. There were some early studies that demonstrated that patients without cardiac activity have a very zero survived in this particular study, but probably a little bit more research needed before making any definitive statements about the use and integration of ultrasound for termination resuscitation. Whole blood. There's a lot of systems that are integrating whole blood or packed red blood cells into their system. And since it's not really widespread in the EMS system in the US currently, at least, need to really kind of think about how this might impact some future guidelines. REBOA, I do want to acknowledge that recently I think it was last month, there was a paper that came out where it's one of the surgical groups did not recommend it, but I don't know if it's fully put to bed yet as an intervention that might be indicated. Certainly not in a lot of kind of American systems where there's not as many physicians in the field. And then thoracotomy, pre-hospital resuscitative thoracotomy. Is there kind of ever a role for it? And, it probably depends on what EMS clinicians you have and their level of training in the field. So this is just kind of more personal things I learned through this process, is that EMS data is just exploding. There is just so much data out there as we have these health information exchanges, especially internationally too, as there's just a lot of registries that exist that integrate with kind of outcome data. There's going to be more and more and more. You kind of see this with the ESO data collaborative. However, this is still really mostly retrospective data, and the kind of work is cut out for, I think, the field of EMS in doing a lot more randomized control trials and a lot more kind of definitive studies. But there's opportunity for perhaps people here. And the other thing that I kind of personally learned about just position statements and guidelines in general is that they are science. They're also expert opinion, and they're also sometimes a lot of compromise, especially when you're looking at these large groups and organizations, all of which have different kind of opinions and perspectives. And there's just a lot of wordsmithing, people that feel passionately about certain phrases and, really just compromising same with an EMS and making kind of policies will go a long way in moving things forward. So that's really kind of all I had here. Want to open it up to some questions.
Absolutely. Wow. This is a really great presentation. Thank you so much for the work. I wish I could have been a fly on the wall during some of those, you know, conversations, if you will. And I do want to open it up to several people on this call. You know, I think that what you laid out here, it's not just a shift in protocols, a shift in mindset for many people. And I think that what I would like people to think about as you're thinking of your question is, you know, how does this new position statement intersect with your own system realities, right? What is your access to trauma centers? What's your scope of practice? What are your scene dynamics? And then how do you approach, you know, traumatic arrest in the field in general? So this update is very important. I know what many people are thinking on this call, because I see some of them, which is how does blood relate to this? And you mentioned it. I think that's definitely going to change the game. Like you had mentioned, the data boom is here, which is great. We have to understand how that's going to fit into what we're seeing specifically with traumatic out of hospital circulatory arrest. So with that opening statement, let me first bring in, I see his hand is raised, a trauma surgeon out of Boston Medical Center, a good friend and a blood warrior. So Dr. Crisanto Torres, come on in, my friend.
Hey, thanks a lot, Peter. Dr. Breyre, am I pronouncing that right? Is it Breyre?
Oh,
yeah.
Yep.
Excellent, excellent review and discussion of the position statement. But I am curious, like, what was the conversation? Was there any consideration of like even a conditional recommendation about, you know, pre-hospital blood, whether it be any type of blood product? Because you know, the thing here is that sometimes I hear, you know, colleagues, whether it be mostly I want to say on the EMS side, EMS physicians will say, we're just waiting for more data to come out. But if I understand, with, you know, you have the UK Swift, Troop and Tower, none of the comparison groups are looking at blood product versus crystalloid. Everything is either whole blood versus blood product. So I don't know what they're waiting for. I think because that's kind of been put to rest that crystalloid is not the thing to go. I'm trying to understand, one, was there any discussion about that, and what are your thoughts on that?
Totally. You'll notice crystalloid is not part of the algorithm. But there is definitely kind of room maybe in the future under those life-saving interventions. I think blood could be there. You know, the question whole blood versus, you know, packed blood cells, it's kind of a good one. You know, it definitely it came up as a conversation point. I just think the vast majority of EMS systems in the US, you know, are just don't have the ability to do blood, and you know, just didn't want to make a recommendation that was not attainable to kind of move that needle. But you know, I think the whole idea with these guidelines is that that's room. So you know, in 5 years' time, I would love to see that as a, you know, more strongly recommended and really just more evidence and supportive out there. So
Yeah.
that's it. Point you raise.
Absolutely, because I think, and I'm not going to hog up the time here, but I do think that we still have to figure out, you know, who's the best patient that's going to benefit, the who and when as well. Thinking about the EMS system characteristics, you know, because you have to think about like geographic issues, environmental issues. Because as an EMS, if I'm in the shoes of an EMS provider, I'm on the scene, I have to think, is this the patient that should get it, and then are we going to have time to get to that patient as well? Because I think you can have the product, but if you can't execute the product in an appropriate, timely fashion, then it's not going to work. I mean, refill is a prime example of that. So thanks a lot, though.
I have a little comment there too, as a very solid middle author on this. I think the evidence behind blood is developing, right? And there's a separate position statement within the trauma compendium that addresses blood over crystalloid, et cetera. And I think there's a separate position statement to that one that said no to the crystalloids specifically. And so we didn't include it here because the specific evidence in traumatic circulatory arrest is definitely missing. I think that there's always going to be this debate of like what is salvageable and what is not salvageable for this like super tough resource to acquire for some systems. And so I think that's kind of part of why it was discussed but not included. I foresee like blood not needing the randomized trial for like hemorrhagic shock. I think that like agreed, like we're doing trials of like blood versus blood now and like different components, etc. But truthfully, there might be space for a randomized trial for this specific population to say like who's salvageable and who's not. Are we wasting too much blood product? So I don't know. I thought that was interesting from that discussion as well.
I think it's going to come down to compressible, non-compressible. If I just look at the Palm Beach County data, we have it's somewhere in the range of 50 traumatic arrests who got blood after they arrested, 0 survivors. We got a couple ROSC. You'll talk to other people who have had a compressible hemorrhage, so they were able to put a tourniquet, refill the tank, get the guy back, and the guy walked out. So I think that we have to almost like these Utstein criteria of which patients should get this valuable resource. But I want to go to Tanner, but I want to go to Dr. Pepe because I know you got to go to your webinar. Paul, make some comments on this circulatory arrest.
Yeah, I'm already on the other thing, but all right, just 3 quick points. I'm sorry, just Amelia, thank you so much for doing this. This is fantastic. There are 3 points. One is that in each one of these cases, we've got to get away from the binary, this is good or this is bad. It depends on the situation and the individual patient that you find out, what approaches and what other interventions you do. Number 2, I just wanted to know, I'm going to be addressing the whole issue about the about the choice of fluids in the Eagles thing. I've been asked to come on. Okay, hang on. Let me tell them. I'm on another call right now. I'll be right with you. Okay. So I am basically going to be talking about this whole issue next about what resuscitation fluids on the Eagles thing. I've been asked to do that by Don Jenkins. Secondly, is that the third thing is that on the Airway thing, when they just heard this Airway, we found ironically, paradoxically, that the endotracheal tube actually correlated with a good outcome, both in Seattle and later in Houston. But because we did it in such a way that we gave a large breath to keep the lung expanded so circulation could go through it, and yet avoided positive pressure events. So maybe once every 10 seconds, et cetera. And we actually had great outcomes there. So that's a whole nother drill down area at another time. And I apologize for having to get off here because I have a lot of people coming on to my call that I've got to switch over. So, okay. So
we'll be right there, Paul.
Yeah, if you want, I'll be very glad to give a talk about that, later on, because that's a key part to get you improve your survival. Because if you don't do it, your time that you will tolerate that period goes down in half. Okay, so thanks. I'll talk to you later. Bye bye.
Thanks, Paul. All right, excellent. Let's go to Tanner. So Tanner, you have used the aforementioned ESO database. You are our research brain on this call, so I'd love to hear your comments. Go ahead.
Sure. Yeah. And I just want to say, thanks again for your presentation. It was a joy of a position statement to read. I think I really enjoyed reading it, which isn't always the case with these manuscripts. But so, my primary interest is in non-traumatic out-of-hospital cardiac arrest. But my dissertation chair is a trauma surgeon, so sometimes he twists my arm, and we have done some traumatic cardiac arrest studies, including one that it did miss the deadline for your literature review. It was published in 2023, where we looked essentially at whether interventions performed on scene, so looking at airway management, epinephrine administration, et cetera, whether that increased your probability of having return of spontaneous circulation at the emergency department. Kind of the rationale behind that was, from the perspective of a trauma surgeon, looking at the East and West guidelines, if you have a patient who arrests in the pre-hospital setting, that like not witnessed by EMS, and they come into the emergency department, right? Most of those patients are just getting efforts terminated, right? But if they have return of spontaneous circulation, then they qualify for more advanced interventions, right? Then we're going to pour blood products in, laparotomy, right? Then we're going to maybe do thoracotomies in the emergency department. And so we were interested in kind of interventions that facilitate that ROSC at emergency department arrival. And so from that study, I think there's a couple maybe lessons that we learned epidemiologically from the United States that I'd be interested to hear your comments on. So first of all, in terms of epidemiology, and it's kind of difficult with the ESO data set to do this, but when you kind of parse things out into penetrating versus non-penetrating mechanisms, most of the United States is seeing non-penetrating traumatic cardiac arrest. It's like 90% blunt injury. And then of those, it seemed there was a lot of diagnostic error. So you'd have among these blunt traumatic arrests, very high proportion, like 10-15% were presenting with initial shockable rhythms. When we looked at emergency department and hospital diagnoses data, they were being diagnosed with STEMIs, pulmonary emboli, a number of different medical conditions that are suggesting that people are crashing their cars after having medical arrests or falling off roofs, construction workers after having medical arrests. And they're being treated as traumatic arrests. They're being scooped off the scene and driven to level 1 trauma centers. And they end up having medical etiologies of arrest, right? And so I think there's I'll have your comments there on the epidemiology and the relevance of these guidelines to the actual population of cardiac arrest patients that we're seeing. Our results suggested that doing things that are likely beneficial for the non-traumatic cardiac arrest patients, right? On-scene resuscitation with early epinephrine, right? That benefited the patient population of non-traumatic cardiac or traumatic cardiac arrest that we saw in the ESO data set. We hypothesized that might be because that most of the traumatic cardiac arrests that are being treated by EMS actually have a normal circulating blood volume, right? It's the traumatic brain injuries, it's the impact brain apnea, the people who arrest because of hypoxia. And so they may benefit from being treated according to kind of a standard ACLS pathway. And so I'm interested to hear your comments on that. I also wanted to highlight, so since the publication of the position statement, I know epinephrine in traumatic cardiac arrest is a hot topic. And the paramedic 2 investigators published a secondary analysis this year looking at only patients with traumatic arrest, stratified by whether they were randomized to the epi arm or the placebo arm. And they found that, again, in traumatic cardiac arrest, epinephrine administration tripled the odds of return of spontaneous circulation. And the only traumatic arrest that survived with a good neurologic outcome got epinephrine. And so, perhaps, again, I agree. The patient that's hemorrhaging, the patient that has some circulatory deficit, epinephrine probably isn't the solution there. But for the undifferentiated population of traumatic cardiac arrest patients that is being seen by the average EMS clinician out there in the United States, would this change your recommendations?
No, those are all great points and great questions. First of all, I want to invite you in 5 years' time to write the update of these guidelines, especially given your familiarity, it sounds like, with kind of, interim research already, which is speaking to kind of how dynamic this field is, how much research is coming into EMS. So yes, nominating you.
Don't be stealing Tanner from me. Don't be stealing Tanner from me.
This is a collaborative. Yeah.
I'm kidding.
So that's awesome. First of all, the in-depth kind of research that you have there, and I do think I want to just highlight and maybe I didn't emphasize this enough though, but that first decision point there, traumatic versus medical. Yeah, no, sometimes it's not that clear. It's not just yes, no, especially kind of in older patients. When you get to those geriatric patients, it's both the heart attack that preceded the car accident. And so, and this was speaking of issues that were discussed with the surgeons, if there is any whiff of this being medical and etiology, if there is any concern, then you do both. Then you put the epinephrine back in. Then you do the chest compressions. Then you do the ACLS and kind of manage the trauma. And that's, as emergency medicine physicians, we do that all the time with kind of medical codes where you're kind of thinking, is it trauma? Is it medical? But you treat and diagnose at the same time. And, I realize that algorithm isn't laid out in this way, and it's really meant for kind of the more cleanly traumatic patients. But acknowledging the realities of what we see and how we deal with uncertainty all the time, and the comfort that we have with that is part of the trade.
Well, let me ask you then, is there a way to differentiate those two patients, a circulatory arrest versus a non-circulatory arrest on scene? And I know we talked about POCUS. I'm looking at Gordon Miller from who is like our brain, who we steal everything from, who's looking at VCO2. He just put it in the chat. So he's using the Hamilton T1 to look at a marker called VCO2, which actually hopefully we're going to work with him to study. But is there a way, Amelia or Tanner or Gordon, about trying to differentiate which type of traumatic arrest we are truly dealing with, to Tanner's point?
Not that I know of. And I really, that would be in part, that's why I kind of lumped them together. I kind of got rid of that penetrating and blunt, is because it is a little bit, I like simple. Simple is so, ideally in my ideal world, you would actually even put like some parts of traumatic and medical together, and like cardiopulmonary arrest, circulatory arrest. The diagnostic uncertainty. I'd love to learn more.
Yeah, Gordon, you wanna just talk for a minute or two about what you're doing, and then we'll go to others.
So yeah, we don't have a whole lot of time to go to complete volumetric capnography, but obviously when you get off the call, you can kind of research it a little bit. Something I've been working on for probably about the last 6 months or so, and some of the trends I've seen with it are very interesting. It literally, I use end tidal for nothing but confirming airways now. The data discrepancy in them are huge, and you would be able to basically say, well, we have this patient, we intubate them, trying to determine, okay, was this medical or trauma? Just from the readings of that volumetric, I could tell very easily whether I have a bad metabolic problem where I think this patient has bled to death or it's a medical issue. Very few medical patients have decreased volumetric. All of the trauma patients and patients that have any kind of hemorrhagic shock have all had VCO2s in the tank, when end tidal would be completely normal. Last one I had was actually a medical code, and this was a really good example. She was a cancer patient on chemo, had a hemoglobin of 5. Her end tidal during transport was 35 to 36, completely normal. Her VCO2 was a quarter of what it should have been. It was somewhere in a 1.5 mil per minute. And I knew, like, this woman, I'm like, she needs blood. And of course, it's not our guideline yet to do that by volumetric. But as soon as we got to the hospital, they started transfusing her. We actually had ROSC on her. So that was a very impactful patient I had. So hopefully the data in the next year or so, it'd be some amazing things come out of that. And we could differentiate, is this patient truly, have they had a hemorrhage issue, or is it medical? Obviously, it takes a T1 ventilator. It can be done non-invasively or invasively.
Right.
No.
And so, I'll go ahead, Amelia, go ahead.
Oh no, that's just really exciting work that just pairs so nicely with kind of pre-hospital blood and really cool.
Yep.
Looking forward to hearing more.
Nobody steal that. Gordon came up with it. We're going to be studying it. If everybody wants to join us with that, if you have a Hamilton T1, we are definitely going to be engaging with that. And I'm going to have Gordon come on the webinar. Lou, I see that your video's on. I'd love to hear your comments. Chief, go ahead.
A couple of things. So one, overall, circulatory arrest also includes circulatory compromise, but that's not exclusive to trauma. Overall, there's traumatic arrest and there's medical arrest, because medical arrest can include many of those circulatory compromises, hence the H's and T's. So I think overall it needs to be not circulatory arrest, but traumatic arrest, likely etiology, versus medical, likely etiology of the arrest, and treating it according to that. Second, and I'm glad I had coffee with Tanner once and I've rubbed off on him. So part of what he said is true. You have an accident, especially doesn't make sense, car ran off the road. Always consider that medical cause is likely the etiology rather than a traumatic arrest. And last, he mentioned about epinephrine and variable results. Maybe it's how we give the epinephrine. Maybe the blast of 1 milligram is not the way to do it. Either push pressure or slow drip or something might be better indicated for some of these circumstances. Like I always said with the EMS systems, if you've seen one, you've seen one. Same with cardiac arrest. The circumstances are never exactly the same, different patient, different downtime, that we need to individualize how we treat and stop globalizing and trying to cram everyone in the same box.
But Lou, the epi studies must be right. They were done in 1968 on dogs, 10 kilogram dogs. So the 1 milligram epi must be, I mean, come on. You can't argue against that, can you? Okay, joke.
Not really, but hang on. My expert's back here. I'll ask him.
Close your ears, little puppy. Close your ears. We're not coming after you. Let's see. So I don't see anybody else's hands are raised. I know we're a little over time. I always like to give our guests the final word. Amelia, you got a great audience here today. We had people on LinkedIn. We're going to put this on YouTube. If you're advising people here today who don't have protocols that address this, that just have a cardiac arrest protocol per se, what would you say that they should at least try to focus on this next 12 months at their agency? What's some words of wisdom that you would give them?
Oh, gosh. I think that number one and foremost is really, as EMS folks, collaborating with your trauma surgeons. What do they want you to do? What are they going to do? What interventions? And that'll kind of really dictate a lot of the interventions you do in the field, because ultimately they're the ones who are going to be receiving these patients. And if they're not going to be doing anything about it, then what are we doing with them? So it just foremost collaborate. And then second of all, just, reconsider the chest compressions and reconsider the epinephrine. I guess we'll put an asterisk on that, but yeah, that's it.
Right. And then the other thing is, are you in favor, just while I'm thinking about it, we have moved to finger thoracostomy. That's becoming more of a trend. There's some data out there. I think one paper out of Texas showed a 5% survival when the patient had a finger thoracostomy. Are you in that camp with respect to EMS systems moving towards that rather than just a needle?
Yeah, I'm a big fan of finger thoracostomy, the simple thoracostomy. And I will say just there is a separate trauma compendium position statement just about that as well. So it could be another potential topic. John Ling is the primary author on.
Well, I mean, I think in that case we have to normalize that procedure more than we have in EMS, because I go around the country and I say I put a finger thoracostomy and people are like, they sit back in their chair like, I can't believe that. But I think it's an EMS scale we should be doing it. Santo, I see you shaking your head. Are you in agreement with that? You're the only.
I am. It's funny because you know about the issues that we even have about with blood transfusion. Can you imagine me bringing up, finger thoracostomy up here? Oh man! So I mean, I think it's great. I think it should be part of the that skill set scope of practice, and so that's another kind of like uphill battle I can see in the future.
Well, you got Leo Reardon right there on the call. He's gonna make
Right.
All you gotta do is make Canton fire. We'll go live. Leo, you're gonna make it.
Don't tempt me. I'm all about that kind of stuff. So
Okay.
all he has to do is nod his head yes, and I'm like, okay, I'll try it. Why not?
Okay. All right. With that, Amelia, thank you so much. Charlie, thank you as well for being on, and thanks for everyone for participating. Please join Dr. Pepe's webinar in progress. If you want to get CME, there's the numbers. And again, thank you so much for joining. We will post this on YouTube by the end of the day. It'll be the 200th and 30th presentation we've had, which has been just phenomenal. So Dr. Breyre, thank you so much, and appreciate you guys, and have a great weekend. Bye, everybody.
Thank you.